Welcome to this video detailing a clinical case study, the sleepy schoolboy, presented by Dr. Hassan Adam from the Emergency Department at Rippus Hospital, Brunei, on September 21, 2023. In this video, we will cover the case presentation, the diagnostic dilemma and initial treatment, general information about snakes, specific details on crate snake bites, and finally, the case outcome and prognosis. The story involves a 5-year-old boy who was playing in front of his house that morning. By noon, he was noted to be weak and was brought to the emergency department by a private car. There was no history of injury or seizures. Upon general assessment in the ED, the boy was found to be afebrile and lethargic. He was not experiencing pain, was not dyspneic or tachypneic, and maintained fair hydration. Examination revealed a GCS score of 15. Specifically E4, V4, M6, with mild ptosis but equal pupils. Other vital signs were relatively stable, and there was no obvious external injury. A venous blood gas analysis showed a pH of 7.32, a PCO2 of 45.3, a base excess of -2.9, and a potassium level of 3.6. Approximately 30 minutes later, the patient's condition changed. His GCS dropped to E2, V2, M6, his heart rate increased to 172, and he began to experience drooling, despite stable blood pressure and oxygen saturation. These clinical findings presented a diagnostic challenge, prompting the medical team to reassess the situation. Given the progression of symptoms, a decision was made to proceed with intubation. Further investigation into the case led to unexpected findings, shared here courtesy of Professor Singh. The patient had suffered a snake bite. The initial treatment included neuropolyvalent antivenom, administered as a 60-minute infusion, along with IV chlorpheniramine, hydrocortisone, atropine, and continued saline hydration. The specific neuropolyvalent snake antivenom used in this case is designed to neutralize venom from species including the Malayan krait, cobra, banded krait, and king cobra. Administration protocols require the freeze-dried antivenom to be reconstituted with the supplied solution or sterile water. The initial dose typically consists of 60 milliliters, given by slow intravenous infusion. The clinical picture became clearer when the snake responsible for the bite was found, confirming the diagnosis. This patient was intubated and subsequently admitted to the pediatric intensive care unit for further management. Next, we will explore some general information regarding snakes and their classification. There are approximately 3,000 known snake species, of which about 300 are venomous. In the Southeast Asian region, roughly 200 species have been identified, with about 50 being venomous. Snake bites are significant environmental hazards and represent a medical emergency. However, it is important to note that antivenom is not required in every single case. Furthermore, the absence of visible marks does not necessarily preclude a bite. Snakes are broadly classified into 3 families based on the effects of their toxins. The Elapidae family is primarily neurotoxic. The other 2 primary families are the Viperidae, known for hemotoxic effects, and the Hydrophidae, which are associated with myotoxic effects. The Elapidae family includes several well-known snakes, such as kraits and cobras, among others. Kraits, belonging to the genus Bungarus, are a significant group, with 16 known species in Southeast Asia. The Malayan blue krait, or Bungarus candidus, is characterized by short, thin fangs. It is sometimes colloquially referred to as the 5-step snake. Other notable species include the red-headed krait, the red river krait, and the sind krait, which is notable for its ability to survive in snow. Importantly, not all kraits are banded. This image highlights the visual appearance of the Malayan krait. The following slides show various other krait specimens, illustrating the diversity within this group. Here, we can observe the distinct patterns found on these specific krait types. Each species exhibits unique characteristics, as seen in this visual reference. Finally, this image provides a detailed look at another example of the krait family's variety. Moving on to the composition of snake venom, it is a complex combination of proteins and enzymes. This includes metalloproteins, procoagulants, phospholipase A2-like substances, and pre- or postsynaptic neurotoxins, such as alpha and beta bungarotoxins. These components often work together, producing a synergistic effect in the body. Regarding Crite neurotoxins, they are predominantly presynaptic. For instance, beta bungarotoxin, which functions similarly to botulinum toxin, along with phospholipase A2, causes the release of acetylcholine at the neuromuscular junction. This eventually damages the nerve endings, preventing further neurotransmitter release and response. Let's now discuss antivenom, often referred to as AV. Antivenoms are immunoglobulin antibodies purified from the plasma of animals that have been inoculated with venom. They can be formulated as either monovalent or polyvalent, with polyvalent being more commonly used due to its cost-effectiveness and practicality. However, antivenoms are relatively expensive and generally have a short shelf life. The indication for administering antivenom in cases of Crite envenomation is when systemic signs are present. These may include stosis, drowsiness, drooling, speech difficulties, shortness of breath, and paralysis, or sometimes unexplained abdominal pain and hypertension. When administering antivenom, remember that the sooner it is provided, the better. Always ensure a crash cart with adrenaline is within arm's reach. The typical method is an intravenous infusion, generally using 6 to 10 vials, following manufacturer recommendations and local protocols. Doses may be repeated based on the patient's clinical response. Be aware of potential side effects of antivenom administration. These can include early reactions like anaphylaxis or shock, intermediate reactions such as pyrogen responses occurring within 1 to 2 hours, and late reactions, which may manifest as serum sickness. Remember that antivenom is not a magic bullet. It is crucial to reassure your patient, maintain open communication with their family, and timely address other ABCDE related issues. Always buy time for your patient by ensuring optimal supportive care. Reflecting on our case progress, the patient was extubated 6 hours later, transferred to the general ward on the 25th for 2 days, and was discharged well on the 26th. He was prescribed Augmentin and paracetamol for minimal local reaction, and was doing well at a 1-week follow-up review. The prognosis for a patient depends on several critical factors: early recognition and optimal management, the time taken to seek treatment, the availability of antivenom, access to critical care services, the site of the bite, the size of the victim, and the level of physical activity following the bite. We have learned several key lessons from this case. First, addressing ABCs alone may not be sufficient in all cases. Keep a high index of suspicion for possible snake bites, and when history is lagging or lacking, go syndromic. Above all, remember that effective teamwork always makes the difference. Thank you for your attention. Here are the references used in this presentation for further reading on clinical guidelines and management protocols. This concludes our video on the management of Crite envenomation.